was hosted by the Gert Foundation in association with Project Echo and the University of New Mexico, and it's held every Wednesdays with a different theme on each Wednesday. This week, we're going to be talking about Hirschprung's disease, and Dr. Gert van der Merwe has kindly agreed to inform us about Hirschprung's disease. He's going to take us through some of the ins and outs of Hirschprung's disease, as well as some of the endoscopic features of Hirschprung's disease. The chat is open to questions, so please post your questions in the chat. And we should hopefully have some time at the end to take some of the questions, and please feel free to interact at the end. If you want to unmute, you can put your hand up and unmute and ask questions. But without further ado, and to not take any time away from Dr. van der Merwe, I'm going to hand over to him.
Good afternoon. Thanks, Vikash, for the introduction. My connection is a bit slow, so if you don't mind, I'm not going to share my video, if that's all right.
No problem at all.
That's fine. Yeah.
Okay, right. Can everyone see my talk?
Yes, we can.
Okay, good. So good afternoon, everyone. I'm going to discuss Hirschprung's disease primarily in adults. The reason being that it's much less of an endoscopic feature in children, and we're going to touch briefly on the pathology, etc., and then have some discussion about the endoscopy towards the end. All right, so just as a definition, so adults, Hirschprung's disease is defined as Hirschprung's disease being diagnosed after the age of 10 years. Just so everybody knows, so anything before that is not regarded as adult Hirschprung's disease. So by way of introduction, I think it's important that we realize that constipation is a common problem, and Hirschprung's disease is a possible cause of Hirschprung's disease, and because we can manage it and sort it out, making the diagnosis of Hirschprung's disease is quite appealing. But I do want to make a note of caution that I think in gastroenterology, constipation is probably one of the most over-investigated conditions. And as such, I think we must be very careful about over-investigating patients with constipation. Not everybody, or the vast minority of patients with constipation will have Hirschprung's disease. Having said that, however, if we do have a patient with Hirschprung's disease and we can make the diagnosis, we can remarkably treat it and remarkably improve their affected for every female that's affected. And there does seem to be a sort of a familial component. So siblings are affected between 3 and 17%. So in other words, if a female was the first to be diagnosed, if a male child is born after that, they've got about a 17% chance. And also the extent of the involvement of the colon, so whether it's just the recto sigmoid that's involved, or whether it's total colonic Hirschprung's disease. Also, if it was total colonic Hirschprung's disease, the chances are also higher that the sibling will be affected. As I mentioned, siblings are more likely to be affected when a female was affected, or multiple family members were affected. Just talking about the pathophysiology of the disease. So essentially, neural crest cells migrate to the myenteric and submucosal plexuses between week 4 and week 7 of embryonic life. This appears to occur from the vagal-derived neural crest cells, and the migration occurs in a craniocaudal fashion. There's also some suggestion on animal models that there's neural crest cells from the sacral from the sacral area that also join the myenteric plexus, and perhaps that can be an explanation for why rectosigmoid Hirschsprung's disease is far more common than total colonic Hirschsprung's disease. And just a note, bear in mind that Hirschsprung's disease can actually extend to be involving the small bowel as well. And in certain cases, you can have your entire gastrointestinal tract that's got Hirschsprung's disease. This is obviously not compatible with life. Having said that, we understand that it's the migration of the neural crest cells to the myenteric and submucosal plexuses. There's unfortunately quite a poor understanding of what causes this interruption of migration of the neural crest cells. But we do know that there are certain genes that are involved with maintaining the viability of the neural crest cells. So the most common genetic associations is mutations in the red proto-oncogene. That then acts as a receptor and is involved with the viability of the neural crest cells. Trisomy 21 has got a very strong association with Hirschsprung's disease, with about 40% of patients with trisomy 21 being affected by Hirschsprung's disease. There's various other genetic conditions that are associated, but I just highlighted the MEN2A and then also Waardenburg syndrome. Just a couple of other important associations. So patients with Hirschsprung's disease also, if it's a syndromic Hirschsprung's disease, up to 40% of them have genitourinary tract abnormalities as well. So 40% in patients with syndromic and 20% of patients with sporadic disease. And then also about a 10% association with visual impairment and about a 5% association with auditory impairment. So if you do have somebody with Hirschsprung's disease, don't just look at the Hirschsprung's, look for other problems as well. All right, so a typical history with the patients with Hirschsprung's disease will typically have a delayed passage of meconium, and that's defined as not passing meconium within the first 48 hours of life. It can be normal not to pass meconium up to 72 hours, but it's not more than 90% of infants will pass meconium within the first 48 hours. Patients with Hirschsprung's disease, and typically when they only present as adults, they will have a very short segment of their bowel involved, but they all will have a history of constipation since birth, and very important, without fecal incontinence. And the reason for this is because the internal anal sphincter is a continuation of the circular layer of the colonic smooth muscle. The migration or lack of migration of the neural crest cells also involve the internal anal sphincter, and for that reason the internal anal sphincter is also spastic, and for that reason these patients typically don't have incontinence. These patients can very often, because of the colonic distension and bacterial overgrowth, have failure to thrive. The majority of them will have complaints of abdominal pain, abdominal distension and colicky abdominal pain, and then it may present with complications of the disease, and these complications can be life-threatening. So the most common problem that these patients develop is a Hirschsprung's associated enterocolitis. This is obviously because of the bacterial overgrowth and stasis, and because of the infection that you then get, you can get bacterial translocation with systemic sepsis. With the enterocolitis, they can have a degree of diarrhea, but most commonly abdominal distension and pain with nausea and vomiting. Majority of these patients, especially if it's been there for a while, will have a megacolon, or at least areas of the colon that are massively dilated. And with enterocolitis, these patients can also present with a toxic megacolon that may require emergent colectomy. So when do we have to suspect the Hirschprung's disease in adult patients? So typically, as mentioned, the long history of constipation, and essentially needs to be since birth. There's no reason really why a person should only become symptomatic of the Hirschprung's disease later in life. The history should be really there from the start. These patients, the majority of them will have a degree of abdominal distension. And when examining them with a digital rectal examination, you typically will find a very tight anal sphincter. With adult Hirschprung's disease, the squirt sign, whether you get a rapid evacuation or decompression of the colon after a rectal examination, is much less outspoken in the majority of cases, but it can still be there as well. So just looking at the differential diagnosis, obviously, first of all, is going to be the functional constipation, which is the most common cause for constipation. Also need to think of obstructed defecation syndrome. The rare condition is internal sphincter achalasia, where the internal sphincter is also spastic, but the rectum above it is not aganglionic. You also need to think of metabolic causes: hypothyroidism, hypercalcemia, and hyperparathyroidism, and then chronic intestinal pseudo-obstruction. And then again, with chronic intestinal pseudo-obstruction, you have to think of all the psychological and drug and all of those other things that we need to consider when we're thinking about constipation. So if one suspects it, how do you go about making that diagnosis? And the first step in adults is doing a anorectal manometry. These patients, if you have Hirschprung's disease, you will have an absent rectoanal inhibitory reflex, as I mentioned, because of the lack of migration of ganglion cells to the internal anal sphincter as well. If a patient has an absent rectoanal inhibitory reflex, it's not pathognomic of Hirschprung's disease. There are other causes as well, notably internal anal sphincter achalasia as well. But essentially, if the patient has a rectoanal inhibitory reflex intact, they don't have Hirschprung's disease. Other investigations that one can do is a contrast enema. Now, the problem with contrast enemas is the false negatives that you get from there. If a person has had a digital rectal examination within 24 hours of having the contrast enema, and even just the insertion of the catheter to perform the contrast enema, can actually cause dilatation of the rectum, and then your contrast enema will not show you the typical transitional zone that you would want to see. And then also the other feature on contrast enema that we're going to be looking out for is a reversal of the rectosigmoid index. So what that means is the sigmoid is always on a contrast enema of a smaller diameter than the rectum. So your index is normally more than 1, and with a dilated rectum, or at least with a dilated rectum, your sigmoid, or the section of bowel that's not involved above it, will have a larger diameter than the rectum will. And then obviously, to absolutely confirm the diagnosis, the gold standard is a full thickness rectal biopsy. and looking for a couple of things. The most important is the lack of ganglion cells in the area. But also we can look at calretinin, and we can look at acetylcholine, and we can look at nerve hypertrophy and so on, which I'll just show you a slide of a bit later on. So just looking at the anorectal manometry on the top left, in the picture on the furthest to the right, is a indication of the rectoanal inhibitory reflex. And what gets done is the manometer is inserted into the anus and rectum, and what we see, I hope you can see my cursor. What we see there is the internal anal sphincter at rest, with some pressure that it exerts, and then as you start filling the rectum, and typically with about it starts at about 50 moles of volume, you get relaxation of the internal anal sphincter, and that's the rectoanal inhibitory reflex. Here's obviously on a different machine, a patient with Hirschprung's disease, and here we see the tone of this band is the tone of the internal anal sphincter, and you can see the pressure going up there in the rectum with absolutely no relaxation of the internal anal sphincter following the insufflation of the rectal balloon. On our contrast enema, this is typically what we will see. So we see a dilated proximal colon within our transitional zone over there, and it's always has this sort of irregular appearance because of some ganglions in this area. So it's and then it narrows down very nicely into our rectum. And as you can see, the diameter of the rectum there is much smaller than the diameter of the colon proximally, and that would be your rectosigmoid index that's less than 1 then. Here's a slide, or two pathology slides. On the left-hand side is a patient with Hirschprung's, without the Hirschprung's disease, apologies. And the black arrows here are pointing to the ganglion cells that we see over there. And the white arrows here are pointing at the nerve fibers that we see, so sort of nice and small nerve fibers. On the right-hand side, the black arrows are now pointing at the nerve fibers, and you can see they're much more prominent on the slide. And there's none of the ganglion cells are present. I didn't include slides to look at the calretinin and the acetylcholine and all of the other things that they look at, because I think this is principally what we need to look at. Important just to say with adult Hirschprung's with adult Hirschprung's disease, we want biopsies, full thickness rectal biopsies is the gold standard, and you need biopsies in 2 areas. So we take biopsies in the anal transitional zone, and there you would expect some ganglion cells in that's from the anus side, and then 4 centimeters above it, where you would expect aganglionosis in these patients. So looking at the traditional management of Hirschprung's disease, so patients with short segment Hirschprung's disease can be managed medically to some extent. We do regular rectal washouts in these patients, and the thinking behind this is to decrease your bacterial load, and that's largely what we use to prevent enterocolitis is the rectal washouts. And patients with short segment Hirschprung's disease, you can get them to pass stools with enough laxatives as well. The traditional surgical management will always involve a resection of the affected segment, and then with various reconstructions that can be used. So I'll show you slides of that now. each have their own advantages and disadvantages. So the Duhamel, the Yancey Suave, and the Svensson procedures, or the surgical procedures, often referred to as a pull-through procedure. And then a transanal myomectomy is reserved for ultra short segment Hirschprung's disease. So what we see on the picture on the top left is essentially we have our ganglionic colon up there with the aganglionic segment over there. So this is prior to resection. So with the Duhamel procedure, we essentially resect that part, but we leave a part of the rectum, and we basically dissect posterior to this distal part and do a side-to-side anastomosis of the colon to the rectum, leaving a piece of aganglionic rectum intact there. So the advantages of this is avoids pelvic dissection or dissection very deep into the pelvis. Although this lower part of your anastomosis posteriorly has to be at the most 2 centimeters above the dentate line. But because we're only dissecting posterior to the rectum, you have less chance of causing genitourinary dysfunction, and with a pelvic dissection, it's always an issue with sexual dysfunction and infertility, as well as problems with bladder voiding due to injury to the hypogastric plexus. The Yancey Suave procedure essentially is a procedure again where the diseased segment or the ganglionic segment of the colon is resected, and the procedure also avoids pelvic dissection to some extent, because the cuff of rectum is left over there as demonstrated, and the mucosa is removed from that, and then the normal bowel is, or the ganglionic bowel is then anastomosed lower down. This procedure is also partially avoids the pelvic dissection, but because of this cuff of aganglionic rectum that you leave behind there, these patients very often still has problems with constipation. And the Svensson procedure is essentially then a resection of the whole rectum up to the internal anal sphincter, with then a coloanal anastomosis. And the chief advantage of this is that you will have less constipation due to all the ganglionic bowel being removed. Over here we have a illustration of the transanal myomectomy. And essentially what is done here is an incision is made at the dentate line, and then a submucosal tunnel is created, or a flap is created, and then about a centimeter strip wide of the rectal mucosa is excised posteriorly, with the enclosure of the submucosal flap at the end of the procedure again. So this is the procedure that's advised for ultra short segment Hirschprung's disease, and it's also used for patients with internal anal sphincter achalasia, so similar procedures. So we're going to move on to novel treatments, which is going to be endoscopic. But before we get to that, I didn't really make a slide on this, because I think it's just worth mentioning in passing. So endoscopic features of Hirschprung's disease essentially is going to be, I mean, you're not going to see any mucosal abnormalities really, unless the patient's got enterocolitis, where you obviously expect to see inflamed mucosa in the ganglionic part of the colon. But typically what you would see is just a narrow diameter of your aganglionic section, within, as you come to the ganglionic section of the colon, a massive increase in the diameter of your colon, and there isn't really much else to say in terms of endoscopic features. So the novel management that I think is probably the topics to discuss on the endoscopic forum is perirectal endoscopic myotomy. This was described for the first time in 2016. I've got the guy's name on a slide. It's just coming up now, but he's done a couple of them, and we'll talk about the series that they published as well. So essentially, with a perirectal endoscopic myotomy, the procedure involves basically inserting the endoscope and just at the dentate line, right at the dentate line, to inject a lifting agent, and then doing a mucosal incision, and then we enter into the submucosal plane, and then dissecting the submucosal plane. If you have a look at this image over here, this is in the submucosal plane with the muscularis propria that we see over there. Your submucosal plane is then developed as far as needed, and I'll get to that now. How do you know how far is needed? So your submucosal plane you then develop, and after the submucosal plane is completely developed, you do a full thickness myotomy. So you basically want to cut through the circular and the longitudinal layer of the muscularis propria. The way to determine how long your myotomy will be is on your you need to do a planning scope for these patients first, and essentially what you then do is EMR biopsies of your transitional zone that you can see the segment just before the before you enter the aganglionic part, if you're coming from the anus. And how that's done is you essentially use a band ligator as is used for varices, and you suction in the mucosa, deploy your rubber band over that, and then you snare that section. Now, this is not a full thickness biopsy, obviously, but remember you would expect to see in your submucosal plexus as well. So it's good enough to see which section of the bowel has got ganglions in the submucosa, and which segment does not. So these are sort of done every 2 centimeters in the transitional zone, and then you determine by that how long your myotomy should be. Just a few comments. So there are case reports of in the literature where they've done long myotomies going up to 25-30 centimeters. I personally would be a bit scared of doing that because of the risk of perforation, because essentially if you once you go outside the mesorectum, you are just basically left with serosa if you do a myotomy over that. But I think this procedure should be ideal to do for a patient with only rectal involvement, and there the aim would be to do the myotomy in the posterior aspect of the rectum, where even if you perforate, there's really no consequence to that. Right, so at the end of the myotomy, an attempt is made at, or the mucosal flap should be closed again as well. So your submucosal tunnel that was developed should be closed. And I think it's a bit difficult because you're at the dentate line. I think closing these with endoscopic clips, like you would do with a POEM or a G-POEM, is a bit of a problem. It's going to be very uncomfortable for the patient. So I would think probably switching that would be closed would be a better idea than endoscopic clips. Just a quick last comment, or do last 2 slides. So this is a case series that was published last year, medium and long-term outcomes of rectal endoscopic myotomy for Hirschprung's disease. Amol Bapaye is Indian gastroenterologist who published the first case in 2016 of the endoscopic parietal endoscopic myotomy. Sorry, a bit of a busy slide. Unfortunately, this paper, I could only get the abstract. I don't have access to the whole paper. So the series that they have is 16 patients, of which 11 were male and 5 female, which fits nicely into the demographic. Then they go on and talking about duration of symptoms, which I think is non-consequential. What bothers me a little bit is that that there was a rectoanal inhibitory reflex present in 5 of these cases. And once again, I don't have the full paper, so I can't really discuss that. And again, also, they had ganglion or absent ganglion cells in only 12 of the 16 patients with ganglion cells in 4. So I don't really know how they whether they cohort, all of them actually had Hirschprung's disease. But I think what is impressive in this paper is the improvement in the stool frequency. So pre-endoscopic myotomy, they had mean of 4.1 days for every stool, and post-treatment 1.4. Laxative usage came down very, very significantly. And then the Hirschprung's disease associated quality of life questionnaire, vast improvement in terms of the quality of life. Right, and that's all I have to say on the topic. Any questions, comments?
Rakesh, are you there?
Okay. Do we have any questions? I see nothing in the chat. Is there anyone that wants to ask anything or any questions? Okay, maybe just a few comments from my side. Yeah, I mean, it is a challenging disease, and the problem with Hirschsprung's is, especially in South Africa, a lot of the patients are picked up quite late, and especially the short segment, the Hirschsprung's disease is often go unrecognized, and they have substantially dilated bowels and substantially dilated problems afterwards. With regards to the endoscopic therapies, one of the good means of diagnosis that has come out is full thickness resections. So using full thickness resection devices, we can easily do a full thickness biopsy in the rectum and make the diagnosis. I mean, that has traditionally been done by the colorectal surgeons by doing a full thickness biopsy in the rectum, but now can be done endoscopically using full thickness resection devices, and it's quite safe. The only problem in South Africa is that these devices are not registered with the medical aids, and they can be quite costly for the patients to fork out the money for the device. So access to them is not very easy. Not many people are trained in the use of the device, but it's quite a quick procedure. It can take you 15, 20 minutes. It's essentially over the scope clip, which closes a hole before you actually make the hole. So it deploys in a V-scope type of clip, and then the snake cuts the tissue that's trapped within the clip, and it's a full thickness piece of tissue. So it allows them to look for aganglionosis pathologically. Just with regards to PREM, it's still, and you did mention it, it's still evolving. It's still very much in its infancy. Still not a lot of data on it. Sounds like it probably will be a promising technique, but probably for the ones that are picked up early and don't have substantially dilated colons, I personally haven't done any patients with PREM. I haven't seen many Hirschsprungs, and the ones that I have seen were very, very late disease. Are there any other comments or any other questions? Prof, would you like to add anything? Okay, if there's no comments or no questions, should we close, Cheryl?
Sorry,
I know it's
sorry,
early.
Vikesh, I was just
Yeah.
a bit out there. No, very nice presentations. Thanks. Just, for the adult gastroenterologist, high index of suspicion. And the only clue to this is constipation from birth. But the point is, it's very unlikely that a neonate who's been constipated from birth will go unnoticed and reach an adult gastroenterologist's office for us to suspect it. So any other pointers that we should be aware of that perhaps we're sitting with a Hirschsprung's?
Yeah, Prof. So I think in that case series, I didn't highlight it now, but in that case series, the mean age of their patients were 14. So they all relatively picked it up early, and the length of their myotomy was on average was 11 centimeters. So I think it's constipation since birth, but none of these patients, they all will have some degree of abdominal distension. And it's pretty much a persistent distension. It's only mild improvement after passage of stools. But then on the clinical examination, a very tight anal sphincter, and I think the absence of incontinence is also very important.
Yeah. Okay, excellent.
So let's not overflow.
Yeah, no, I think that those other pointers are also more useful. So, so it's adolescence. So it's very likely that unlikely that a patient will go unnoticed to adulthood, and most likely will come to attention in adolescence, which is probably a little bit more easier to understand. Okay,
Yeah.
that's excellent. Thanks so much. That's very good.
In my
Thank you
own
for
experience, I've seen probably about 4 or 5 of them. Most of them were in their 20s. There was one patient from out of South Africa, from one of the African countries, who was in his late teens. But I recently, about maybe 5 or 6 months ago, saw a patient in his 50s who was actually undiagnosed and had a long standing or history of constipation. And I suspect he had a very short segment of Hirschsprung's. And he was actually referred to me for a large polyp in the sigmoid colon. And so the polyp was very big, but he had this massively dilated colon as well. And he ended up having surgery, and we did suspect Hirschsprung's. Initially, he had a full thickness biopsy, and it confirmed aganglionosis. So usually picked up earlier, but you can get caught out. That patient was, I can't remember his age offhand, but it was late 50s.
So what were the clues to the diagnosis with that patient, Vikesh?
He did. So firstly, the colonoscopy could not be completed because there was a lot of stool, a poor prep, and there was a massively dilated colon. So, that was the clue. And when you probed him, he did give a long standing history of constipation.
Okay.
Managed with laxatives. He also was quite fearful of the healthcare system and was scared to present. He did suspect that there was something wrong, but was scared to actually present earlier. But I think his endoscopic findings from the referrer's report was suggestive, and then he had imaging done, and his imaging showed a massively dilated colon. When I scoped him, it was all in keeping with Hirschsprung's, and we couldn't complete the scope because his colon was just so big. And these patients, you never get them bowel prepped. Prof. Thompson,
Thank
do you
you.
want to?
Sorry, I got waylaid. I couldn't get here on time, so I missed the talk, unfortunately. But yeah, one of the other things that you see in these African patients, which can be a very big differential diagnosis, is this condition where they get leiomyopathy of the colon. And again, you're wondering there whether or not that represents Hirschsprung's. But usually the the symptomatology is much more chronic and the degree of distension is very much more noticeable. And sometimes they have a whole myriad of other leiomyopathic situations regarding the renal pelvis and other things. So that's something to remember, because it's something that can go into adulthood and can be a missed problem. But yeah, it's really poses problems when things are outside the normal diagnostic window, without a doubt. And you just have to keep your wits about you.
Thanks. Nasif, do you want to add something there?
Yeah, hi Vikesh. Sorry, I missed the last part of the presentation. It's funny, I just saw a patient last week with Jan Levine that was referred to us by the surgeons. And it's a young lady, she was 20 years old, and she's had multiple episodes of fecal impaction. So she was presented sort of last week again to Grootskier. She was also at the Tygerberg circuit over the years. And she had this massively dilated colon and very badly fecal infected. So we were called after she was disimpacted. And so the discussion with Dion was, and myself, were just trying to understand how we get, it looked like Hirschprung's. She was constipated since birth, long sort of history of constipation. So the challenge for us was just that we've lost SASA. And so we don't have the ability to do the anal manometry anymore. And just also the practicalities around doing a full thickness biopsy without the device that you spoke of. So we reluctantly gave her a colonoscopy date, trying to understand what are we going to do when we're actually going to scope her in April. Hopefully it's on Dominic's list. But just some practical advice. We don't have manometry. Full thickness biopsies from the surgeons it's possible, but it's hard for us. So we left at a bit of an impasse, and also like practically what we could possibly have offer this patient. Thanks.
Yeah, I think speaking to your colorectal surgeon and doing a transanal full thickness biopsy shouldn't be too much of a challenge for them. It's not something too difficult for them to do. You should be able to offer them that. Does anyone in your department have any experience with using an FDRD device endoscopically? You can get it in state, but you would have needed to go have done the training for the others. They won't be able to allow you to use it, but you can access it in state. One of the challenges in private is that it's not funded. Basically, it's not registered with medical aid.
Yeah, I think I'd have to ask Prof. Thompson if he's been in the unit for a long time. I'm unsure if we have access to it. My instinct is no. But in the absence of that, we'd have to obviously ask the colorectal surgeons. But it's very interesting because we saw the case on Friday and we're having this beautiful discussion today. Thanks.
Yeah, Nasif, I think, a full thickness rectal biopsy for us as colorectal surgeons is really not an issue at all.
Yeah.
They might give you some grief about about indication for it, and trying to protect the scarcity of the list, but I don't think it's a big problem. And I think in the absence of your anal manometry, your first non-invasive investigation is going to be your contrast enema. But just make sure that your radiologist knows that when they mustn't insert a finger before they insert the catheter, and they mustn't inflate the catheter balloon, otherwise you might lose that transitional zone. And if it's and especially if it's a short segment in the rectum, it can be, if you dilate it even at the slightest bit, then you're not going to be able to see it on your imaging.
Yeah, it's usually not very invasive to do a transanal full thickness rectal biopsy. You go to the posterior wall, it's low risk. You don't even have to close the hole. So it's usually quite accessible for the colorectal surgeons.
Just in terms of this device, Vikesh, is it done sort of on a normal? Do you kind of schedule as a normal at the normal colonoscopy, and just practicalities around using that device if you've used it before?
Yeah, I've used it a couple of times. In fact, I've used it for Hirschprungs as well, to make the diagnosis. It's a normal colonoscopy essentially. And like I'm saying, it's quite quick. It's not very difficult. And for Hirschsprungs, it's easy because one of the big issues with that device is if you need to get to the cecum, it's quite big and it's quite bulky. It's bigger than a normal over-the-scope clip. And sometimes it's challenging to get it through a tight diverticular sigmoid or whatever it may be. Or so getting it to the cecums can sometimes be a challenge, but getting it to the rectum, usually not an issue at all. It's intuitive to use. Look, it can go wrong, and of course, it does need you do need some training with the device, but quite safe, especially in the rectum.
Thank you.
There's only one company so far that does these devices. It's essentially the Vasco company. There's no competitors that I know of at the moment. Anything else? Any other questions in the chat? There's a comment here from Tendai. He says, I'm tempted to do plain x-rays routinely in chronic constipation patients because we do miss these patients. History of constipation from birth or clinical indicators for distension are not always accurate. Yeah, and I think that's a good screening modality. Just a plain chest, plain abdominal x-ray can often give you a clue and a starting point. I think that's not a bad option. And you probably miss less of these patients. Anything else, Prof. Thompson? Do you want to add anything?
No, I think again, sort of it's in amongst all these constipation patients for which there are a myriad of reasons. And again, if you have a simple diagnostic test that you can use safely, then obviously that's what you must do to exclude the diagnosis, because most of the time it's not going to be Hirschsprung's, but you don't want to miss it. And I think there are lots of diagnostic faux pas. And the other thing is that you don't think about it because it is really such a rare entity. So you have to keep it on your radar. That's all I would have to say about it. And again, all these devices for full thickness closure, full thickness biopsy. Again, I think when we ran the workshop at the HPB meeting, again, the sort of, it's really important that you learn how these devices deploy, how to engage them so that you don't make mistakes with them, which is not a good idea.
Yeah, when they go wrong, they can significantly go wrong. If you close it a Vasco clip over the grasper and lock that grasper in, you can end up with a lot of trouble. You can suck in adjacent organs into that cap. So one of the principles is to pull from the grasper and not suck. And so it can certainly go wrong. You can end up cutting and not deploying the Vasco clip, and then you're left with a nice big gaping hole. Again, not too much of a problem in the posterior wall, low down in the rectum. You can get away with it, but yeah, but not ideal as well. I think with that, all that's left to do is to thank Dr. Gert van der Merwe for an excellent presentation and for sharing his insights into Hirschsprung's disease and sharing some of the newer possibilities like PREM. And thanks again to iEcho University of New Mexico and the iEcho team in India. The recordings are available on the Gastro Foundation website. So are all of the previous recordings. Thanks to Prof. Castanidis, Prof. Thompson, the Gastro Foundation, and thanks to our sponsors as well. Next week is an IBD session, so we hope everybody joins next week as well. And with that, we close, and thank you to all of the participants for joining and sharing your time with us.
Thanks.
Thanks very much.
Thank you.